There was a professor of mine years ago that challenged a doctoral group and said there's no such thing as an original idea. And everyone basically first thought, oh yeah, I'll come up with one. Well, after 3 months of going and presenting different, what we thought were original ideas, he would go back into time, like this particular quote. This presentation is based upon this quote. It is more important to know what sort of person has a disease than to know what sort of disease a person has. 400 BC. So this is not an original idea. What we're talking about is the biopsychosocial model. It goes way back. My background, one of the most prominent things that created me going into the field of psychology as well as pain psychology is that my mother had one of the very first lumbar spine fusions. That was over 50 years ago, 55 years ago. And she was June Cleaver, for those of you who remember Leave It to Beaver. She loved being a mom. She was a great cook. She was the most beautiful mom on the block. Sweet, nice, wonderful. And then due to her structure as well as the way that she would lift everything she could, she didn't even pay any attention to ergonomics. We didn't even know about that then. And so she had to have a fusion. Well, like many fusions, I'm not saying, especially back then, it was unsuccessful. So my mother became a chronic pain patient from the time I was 12 years old on. That was a major impact on my life. I experienced what can happen to a family. My father had such a difficult time just hanging in there. And so I've experienced the effect of chronic pain from a personal perspective, which I believe has helped me have empathy and understanding of my patients over the years. Some of the other things, I won't go through all of these, but I have been involved in pain psychology for 33 years. I'm a fossil right now. And I have seen approximately 4,500 injured patients. This is all I do. This is my specialization. I actually, people will call me and ask to see me for like depression and things of that nature. I only work in the context with patients who have an injury or medical condition. I had a contract with CORS for 10 years where I worked with their delayed recovery patients. And it's interesting, for something like 8 years, they had not allowed any of their patients to go to a pain program or work in the whole area of pain management, because they had sent 20 employees to the inpatient programs, and they went 0 for 20 as far as getting anyone back to work, to the tune of about $500,000 for those 20 employees. So what they did is they put them in the back wards, I called it. They would be sitting there sorting different pieces of porcelain or whatever, and then they would start, all of the people in the group, the employees would start talking about, well, who's your attorney and tell me about what they're doing, how are they helping you? So it became really very dysfunctional. So at that point in time then, I was able to put a program together that was much more functionally driven, but looking at all factors, the biopsychosocial model, psychological treatment, as well as manual physical therapy for the most part. I was an executive board member on the National Pain Foundation for 10 years with some of the top pain professionals in the world. And the whole purpose of this not-for-profit was to create an educational piece that people could access throughout the world on whatever issue, whether it's migraine headaches or whatever, so that they were peer reviewed. And that was a very, very enlightening time for me. I am the co-author of the Battery for Health Improvement 2, which how many of you are aware of that test? So my partner, Dr. Daniel Bruns, and I began the development of this particular measure back in 1984. and we're still working on it. It's always reminded me of the country western singer that said it took me 25 years to become an overnight success, because it doesn't come quickly. Everyone thinks that you see something that you're using, oh, that probably took 2 months, 3 months. Well, we experienced the rude reality of what it takes to develop these things. We have a short form, which is the BBHI, and we have a new instrument that's called the Medical Interventional Risk Report. And I'll be going through and just kind of giving you some sort of a glimpse of how this works. But I think you'll find it interesting because it deals with issues around addiction history, addiction potential, rehab risk, people who may have a tendency towards not doing as well in rehabilitation, kinesiophobia, the fear of movement, catastrophizing. So there's a variety of things that we'll look at in that area. And Dr. Bruns and I have published widely, and if anyone's interested in various articles that we have published over the years, we'd be more than happy to provide those. Okay, so there's the biopsychosocial model. How many of you have heard about the biopsychosocial model? Okay. How many of you feel like you have a real clear understanding of all the components that go into that? Okay. My experience, and I have primarily worked with training physicians throughout the United States in the whole area of biopsychosocial assessment. I think most physicians and doctors really do understand the importance of these factors, especially the psychosocial factors, but as far as how they can access it and utilize it in their practice, that has been an issue over the years. It's almost as though that's your area, Disorbio, you go do that, I don't do that. Well, the important part to me around that is I believe you all want to know who your patient is. Who's the person that you're treating? Dr. May was talking about that in regards to a surgeon. It's not just a knee, it's not a back, it's a person. It's a human being that has children, so they have psychosocial issues, psychosocial lives. So it's not just a physical thing, it's the whole thing together. The medical home is an example of the integration of the biopsychosocial model. In Colorado, for those of you, many of you may be aware, we are actually a leader in that movement right now through CU, to where the family home, the medical home, is going to be implemented and is being implemented, where you have psychologists, counselors, whatever, along with physicians in different areas to assist the overall needs of the patient. The applications are involved a lot in pain and disability. Think about disability assessment and evaluation. You're not just looking at a physical issue, you're looking at the effect psychologically, because people get disability for depression, for a variety of different mental issues as well. So there's a variety of areas that it is being utilized and has been for a while. The estimates for people who are experiencing chronic pain, this is interesting to me because for the past 15, 18 years, these are the exact statistics that we were looking at years ago on the National Pain Foundation when we were trying to evaluate this. So it's certainly not getting any less expensive, but there is a movement for that to begin to happen, and I'll talk about that in a minute. Americans consume 80% of all narcotics in the world. Is that somewhat of a staggering statistic? It's unbelievable to me. I mean, accidental overdose deaths, Dr. May discussed that, what's happening. But look, it's greater than cocaine and meth. That's pretty shocking. And to me, the most important aspect of this is the cost of the fabric of society. It's mounting exponentially. I worked also at a methadone treatment facility for 3 years. Initially, I got the job because I was told I had a great resume, but I had no experience and no one would hire me. So I said, well, okay, I'll go work, and I was able to get a job at a methadone clinic. Little did I know what that would be like. It was baptism by fire. No one could teach you how to walk up to a street heroin addict and say, hi, I'm Mark, your new counselor. Can you imagine what they said to me? I can't repeat it, but that was over and over and over. It was actually quite frightening. And I was an academic All-American college football player, so I didn't think that I'd be fearful, but let me tell you, I was scared to death. For 6 months, I'd get up and do self-hypnosis and breathing methods so that I could at least talk when I got there. But I learned so much. I always wondered, what am I doing here for 3 or 4 years? I know now why I was doing it, because it certainly helped me deal with the issues that I deal with patients every day with medications. So I understand what happens to people with heroin, narcotics. What we're looking at, it's more like this. It's a Drano. Their lives just go into total shambles. I had a client come in the other day that had just been back to upstate New York. I said, well, how did it go? And she said, well, the sad part is that 1 of 35-year-old men out of 5, 1 out of 5, die from heroin overdose. That's pretty amazing, isn't it? When you start realizing the epidemic that is really going on. And so I think we're all a part of this. We all need to help and begin to do best practices. The other thing about the biopsychosocial model is that it really does require multivariate assessment, multifactorial assessment. It's not, in medical school, my understanding is that the medical model is more diagnosed through exclusion, which makes sense in certain areas, but when it comes to the issues that we're dealing with an injured individual, we need to diagnose through inclusion, because it doesn't mean that we completely fix the physical, the psychological, the social, but if we can get percentages of reductions in those areas, then people can move below the threshold to where they now can then begin to recraft their lives or begin to get back to work in some way. So hopefully the presentation will give you strategies for opioid medication patient selection, job dissatisfaction and how work issues. On the BHI, we have the only job dissatisfaction scale that's ever been developed. And the reason why we have job dissatisfaction is that it has been shown for many, many years through Stanley Bigos' studies up in Washington that individuals who are dissatisfied with their job tasks, coworkers, boss, or company values, and we can look at all 4 of those, are more likely to get injured as well as not to return to work from their injury itself. I'm going to have a presentation also specifically on pre-surgical psychological readiness. That's becoming more and more a requirement throughout the United States in a variety of different insurers and situations. And also rehab risk outcomes. I've mentioned kinesiophobia. Also, one of the things that I would like to have a few minutes to talk about is MMI. How do you approach what MMI means to your patients? Because that's something I get asked all the time. What does that really mean? I believe many physicians and even lawyers that are working with the client do tell them what MMI is, but they don't understand it. So I think simple ways of presenting MMI, I think, is an important thing because it helps people move through the system. Also, the realization that certain people have to come to acceptance. They may be experiencing life issues around limitations that have occurred through their injuries. That doesn't mean that life is over. It means they have to recraft once again. Okay, ACOM guidelines. Are we all familiar with ACOM? Okay, they have their particular guidelines, which ironically are based upon many of the guidelines from the state of Colorado. I just became aware, Dr. Bruns and I were talking about the recent federal mandate. The Department of Labor federally just had a big meeting where they had all the state heads throughout the United States for the Department of Labor. And they were really getting to the whole issue of how can we begin to make injury and chronic pain and recovery from a medical condition less expensive, less a drain on society, make it more efficient, effective. And they said, we're not going to go through and discuss every state and where they are other than one, which is Colorado. And they gave them glowing responses in regards to our guidelines. Now, for those of you, there are many people, or might be a few people here that have been on those committees. It's been going on 30 years. So I think we need to give a hand to the people and the physicians and the different providers that have worked on those guidelines for 30 years in different ways, because they certainly have put Colorado on the map as far as the evidence-based measures right now. There's recommendations for psych referral. How do you know when a patient, when do you know or suspect a patient's going to be a problem, where they may have some issues that are going to interfere with their rehab? Is that something that you get right away? Or does it take you time to pick it up, or do you make a real quick assessment with no data other than what your gut's telling you? That's a very important thing that they're trying to look at, is if you have any suspicion, get someone to assist you as a psychologist or someone that's trained in this area. History of psychiatric disorders. If someone's a schizophrenic, it's going to be real difficult to follow instructions, don't you think, at times? So we really need to look at these various things that they recommend: catastrophic injuries, evidence of cognitive impairments, drug problems, again, and prescriptions, delayed recovery, noncompliance and adherence. This study by Meyer et al. Was a meta-analysis, and it basically determined with 800 studies that psychometric tests are comparable to good medical tests in their ability to diagnose and predict outcome. That's pretty amazing. Is that surprising to you? Is it not? So this is the basis of these various tests and how we can utilize these as a measure, just like we do MRIs or in conjunction. The tests that they are recommending should be standardized measures, which means they have extensive reliability and validity measures to make a determination that you can actually predict these outcomes more scientifically. The Colorado Division of Work Comp recommends psychological assessments prior to some surgeries and for all patients with chronic pain. Here's some of the tests that they recommend that is part of the guidelines. The MCMI-4, which is more of a personality instrument that looks at, based on the DSM-4, it's actually in the process of coming out and it's being changed. The MMPI-2, the MMPI-2-RF, healthpsych test, or the Milan Behavioral Medical Inventory, and the BHI-2R test. And then there's brief psych screens as well. These are recommended by the division. The Battery for Health Improvement 2, which is the instrument that we've been developing since 1984 and continue, is based on the biopsychosocial vortex. Okay, so you can see an individual has risk factors for illness or injury. The onset of the illness or the injury occurs. There's psychological vulnerability like anxiety, fear, worry, anger. As you move around, you see social effects that can have all kinds of variables around loss of job, difficulties with marriage, education gets stopped at times, lack of support, unable to cope. You see how this whole process continues to evolve. So it's a vortex, it's a process. The sooner that you are able to identify and begin to deal with these things and identify where you need to intervene, then the vortex doesn't continue to go round and round and round, because as you see here, escape from the vortex is blocked. Instead of being able to address those things, then it continues to go on, and then you get the delayed recovery and often a worsening of a condition. Validity scales, we have, these are the kind of areas of the psychosocial aspects of assessment. So you can see it's somatic complaints, pain complaints, functional issues on the perception of the patient, depression, anxiety, hostility, borderline personality. How many people identify borderline personality, people with borderline personality? Do you know what borderline personalities are? The best way to describe a borderline personality is if they have consistent conflicts in interpersonal relationships, no matter where they go, that's one of the major indices. The other thing that you as providers need to be aware of, borderlines work from a position of good object, bad object. When a patient comes in and after the first half hour and they go, oh, Dr. Disorbio, no one's ever understood me like this. I can't tell you. I just feel like I'm going to be freed. This is going to be terrific. I know as soon as they walk out the door, oh boy, what do I got to do here? I got to get out of here. I got to do something to deal with this one. Mainly, you do not treat a borderline. You manage a borderline. You manage a sociopath. You manage character disorders. You don't treat them. Because when we're looking at disorders in psychology and diagnosis, it's basically, that's the fabric of their personality. That's who they are. It's not very changeable at all. There's no way of doing personality reconstruction in that context. Okay, here's an example of how we look at the biopsychosocial model and put it into play. You can see the guidelines requiring or recommending pre-surgical evals, American College of Physicians, APS, American Pain Society, International Society for Advancement of Spine Surgery, North American Spine Society. The payers, Pinnacle up here, Blue Cross, various. You can see the states that are recommending that, and that's increasing every day. So how do you decide when to perform surgery? Bob and Dr. Cutter. The MRI shows small herniation at L4, L5. How do you feel? It's a little uncomfortable, but I'm okay. Okay, if it gets worse, give me a call. The MRI shows a small herniation. How do you feel? PT doesn't help, and the pain is overwhelming. I can't work. When you hear that, I can't work, does that kind of give you a little bit of a bristle in the back of your neck and the hair comes up a little bit? Because that's kind of the focus at that moment in time. That doesn't mean that they can work, but their perception is, I can't work, that's it. It's not a very good thing initially. Let's review your surgical options. This is a very important concept, I believe, in pre-surgical evals and making decisions with this. To what degree are surgical decisions based on behavioral measures? What a behavioral measure is what does the patient say? What are they telling you? Objective versus objective test results. So let's look at this. What constitutes a good outcome? X-rays of your fusion look great. Looks like a good outcome. The pain is terrible and I need morphine. Will you fill out my SSD forms? To what degree are surgical outcomes determined by behavioral variables? Let's look at that. Pain reports, opioid use, return to work, quality of life, satisfaction with care. Those are many of the outcome measures. So we need to assess those. Okay, most surgical outcome variables are behavioral. Successful fusion, objective biological. That's objective. Pain, subjective symptom. Reduced opioid use, behavior. Return to work, behavior. Satisfaction with care, subjective feelings. Disability, biopsychosocial model, quality of life, a subjective impression. So you can see, this is how we determine whether it's successful or not. Those aren't necessarily, you can have a success. I have had so many patients over the years that the surgeon, I think, really is accurate in saying, wow, you on return after the fusion, boy, you got a solid fusion. Everything is looking great. Geez, doc, how come I have more pain now than before? Well, I don't know, but I did my job. It looks great. I'll see you. That happens over and over and over in my practice over the years. So it's very important to measure these things because these are the things that will help you understand what you need to do to move forward and make those decisions, because you have to decide, is this surgery really going to change this or that? Is it really going to make that happen? Because if the patient has the expectation that that surgery is going to make everything okay and I'm pain-free, what do you think their feeling is going to be if they don't have 100% resolution? They're disappointed. Now, with pay for performance on the horizon, it's been on the horizon for 30 years, I think, but it is coming more, it's coming, I think. But it's going to be, these issues are going to be very important for people to look at. I want to have a good outcome, so I have to look at the whole person. What do surgical patients say is an acceptable outcome? Pain, less than 3 on a 10-point scale. That would be as successful on average for most patients. Function, return to normal. When I ask the question, well, what do you really want from all of this? Well, I just want everything to be the way it was before I got injured. Did you hear that? That's what I want. Well, I really hope we can do that. But if it's not all perfect, can we still move on and you can recraft your life and move on? Well, I don't know. I really want it to be the way it was before. You know you got an issue then at that moment in time. Good outcome or bad? Good news, the x-rays of your fusion look great. The pain is worse than ever, doc. I can't go to work. Sadly, you'll never be able to work in the oil fields again. Actually, that's fine with me. I hate my job. So at some point, you have no idea unless you really get to the bottom of it. What is it that you want? Do you really want to go back to work? Or is this just lip service? Okay, this is a referee journal article that we completed years ago that we were trying to find what's the consensus on pre-surgical psychological evaluations, because people have been like Dr. DeLays and some of Dr. Van Dorsten, who's here. Other people have been looking at the issues of a consensus around pre-surgical assessments. What are we doing together and finding what do we all kind of see together with this? This is over like 30 years, 25 years. Okay, so we have a convergent model. Primary risks include, for doing surgery, psychosis, suicidality, homicidality, actively abusing illicit drugs, medically impossible symptoms. If a person is so suicidal that they're having a hard time functioning at all, just getting out of bed, or just, I can't function, why would you do surgery? You don't want to do surgery at that time. You want to wait until that gets stabilized, if it does get stabilized. Secondary risk factors are depression, anxiety, somatic complaints, job dissatisfaction, history of abuse, substance abuse. So the primary risk, they're like red lights. That stops everything really at that point, because you can't move on with those severe psychological or issues that the patient's presenting. The secondary are more cautionary. Those are yellow flags. That doesn't mean a person won't get surgery, but you want to stabilize those as best you can. Many times it takes me about 4 sessions to address some of these secondary issues, so a patient I call it an attitude adjustment, where they have a more in line, their expectations are more in line, and they feel like they now aren't just going to go in and have a failure because they have such high expectations that everything's going to be perfect. Failed back surgery syndrome suggests a behavioral failure. A successful fusion, but disproportionate pain reports. Overuse of opiates, does not return to work, litigates SSDI. So a behavioral evaluation helps you to better understand the patient dimension. How many of you as physicians would feel comfortable in actually having your patient take a particular screen from a behavioral perspective and then try to interpret it? When I begin treating a patient, I let them know very soon, I'm not interested in paralysis through analysis in work comp. I believe that we need to have an understanding and insight into people, where they come from, what they're about, but it's really about action, it's about movement. And I think that's what you're talking about. It's like, oh, I know it, but what do I do? Well, I think that there are some new trainings right now through the division to try to assist physicians in learning the different instruments and how they can utilize those and see how each one of those or some of them work in their practice versus another. So there are some things that are going on to assist doctors in this. Now, if you and I work together, I'd say, hey, I'd love you to begin doing this. You can use me for the big stuff, the big comprehensive, but I want you to have an understanding of the portrait of your patient. Who am I working with? Who is this person? What sort of person has this injury? So you can make a determination of, well, there are things that you can help people with, but I'm going to send you to the psychologist or the counselor, but here's a couple of things you can do with relaxation methods or whatever, but let's see how we can get you some help to manage these things. Because it's part of your overall injury. This happens to people all the time. How do you use them? You said you use psych tests? Yeah.
Usually it is, for me, the psych tests really confirm what I already suspect. Just like an MRI of a knee, you suspect a meniscus tear. Psychological testing, I'm seeing a somaticizer or they're depressed or whatever, and usually that confirmed. And then it helps me kind of get that patient into some kind of clinical setting where we can deal with some of their issues. And like I say, typically, most of us know when you've got somebody that is not going to do well. regardless of the physical things you do, the physical therapy, the medications, they're just not going to do well. And those things confirm that for me, and that helps me deal with the patient and move them ahead.
You know, I've heard that for 20 years, over and over, and I believe it. I've worked for two family practice residencies as a behaviorist. That's what they called them, a behavioral counselor. The University of Colorado up in Greeley, and also the University of Utah. I believe that doctors, you all have a gut reaction and you have a radar about people that might have problems that you may need to address. This corroborates that. It helps in maybe a little more depth so you understand where and what, and hopefully some of them have recommendations for the tests themselves, have recommendations for things that you can do. But what both of you have said is what I've heard for over 20 years when I've trained people to do this, doctors. It's like, hey, I know, why do I need a test? Well, part of it is you want to corroborate. Am I picking up what I think it is? Also, from a medical legal perspective, I've seen this a lot over the years where if there was this one attorney that came to me and he said, I want to know about your tests. I need to have some of my doctors give some of these tests. And I said, well, why? Well, maybe they can learn something, but also they wouldn't be in trouble for their having a failure, or they've given narcotics to someone that then they go out and have an opiate overdose. The doctor has actually made an effort to know the patient before they give them the narcotics. So they don't have the medical legal problem. So there's a lot of other variables for the reasons to use psychological tests or psychomedical tests. Okay, now I want to talk just a little bit about the history of opiates. I think that this first one's kind of interesting. Sumerians in Mesopotamia cultivated the poppy plant. The joy plant. I could just imagine when I think about this, the first couple of times that somebody ate it or whatever, that over the years man has found the ways to find these things to make them happy. 1800s, morphine was first extracted, used as an injectable. Addiction was observed. Early 1900s, there was a program on called The Nick, based upon the Knickerbocker in New York. And it was the evolution of surgery. That was what the whole program was about. And the main surgeon, who was quite a radical in many ways, and also he was an opiate addict. He'd go to the opium dens, and then he'd do cocaine to get back up and go into surgery. They still do that? Okay. But it was interesting because during that period of time, in the early 1900s, that heroin, they had cocaine in Coca-Cola. A lot of people don't know that, but that was part of what was involved in that substance. Okay, then when I first started practicing here in Colorado, and right around 1984 to 85, physicians would not, if there's anyone as old as me in here, you'd know this, that they would not prescribe a Darvocet. They wouldn't prescribe anything as far as a narcotic. So the bottom line around narcotics, from my perspective, is you need to understand addiction history, addiction potential, craving, and things of that nature. Okay, I'm going to go through just a couple of cases quickly. This is Mr. Tough. Here's his BHI scale profile. As you can see that he had everything within the shaded area is the average of the average patient. So if you're within that range of shade, that you're average for somatic complaints, pain complaints, functional complaints. If you're above the 60, the one standard deviation there, now you start to look and see this particular patient had a bit of pain complaints, some somatic complaints, not excessive, had some functional complaints, and muscular bracing was within the average. You can see that he did not have tremendous depression, anxiety, or hostility. He was not a borderline personality. He still has perseverance. He feels good about his family. He was not a survivor of abuse and physical or sexual abuse. He likes his doctors. He's very happy with his work. Okay? This man was he had one of the worst injuries I've seen. This is an example of having a horrible injury, but being the sort of person that goes through it and you admire them because they don't complain. They say, hey, I've just got to get better. They will be honest about things. They work hard in rehab. They do everything they can to recover. So that's the patient who is very is really tough, really perseverant, has great resources as an individual. Okay, now here's Mr. Angry. This fellow had an initial injury where he slipped and fell and it was about 8 solid core doors that fell on him. Back then he had a successful L4, L5 laminectomy. 3 years later he had a repeat surgery. Pain did not remit. He began abusing drugs in the hospital, actually. He was doing it within the hospital. He'd have people bring the drugs into him. I'm sure some of you have had that happen. This was his initial BHI. Does that look a little different to you? Just anything beyond the shaded area is above the average of the average patient. He's elevated at extreme levels on like 6, 7 areas at the 99th percentile for patients. So in other words, this guy physically, he's incapacitated, pain-wise, somatic, function. He hates his doctors, and he really hates his workplace. Really hates his workplace. I mean, this has been years of hatred and conflict. So his designated work comp physician agreed to refer him back to the original neurosurgeon who he'd seen before on this back surgery, laminectomy, because he was very qualified, competent, and well-respected surgeon. It was one he would go to and say, okay, I believe him. We did a variety of different extension flexion MRIs. We did some psychotherapy and treatment with Zoloft. But he said, I will have a fusion if I can't get my pain under control. And it wasn't like he's just kind of telling me, he's saying that's what'll happen. This is him 3 months later. And in the meantime, he'd had a fitness for duty evaluation psychologically because they thought, we're worried about this guy. And I think they should have been, and I'm glad they did that. But after intervening with him and being very realistic with him, he was a fellow that I had to be quite frank with, and we had a good enough relationship that he heard it. And I guess I was big enough that he didn't want to mess with me. But so that's an example of a case that could have gone just horribly south. But with assessment, knowing what's going on with the patient, working together as a team, a virtual team with the physicians and all the PTs, we can have some very good success and outcomes. Okay, I'm going to go real quickly through this. This is the medical interventional risk inventory. This is a new screen that we've put together from our tests that deal with some of the common issues that you all are dealing with every day. Okay, on the mirror, you have to have a validity measure. So this is self-disclosure. Is a person endorsing items where there is some form of distress, problems. Now you look at the primary, remember the primary risk factors. Pre-surgical rehabilitation, is it for pre-surgical, is it for rehabilitation risk? Secondary risk factors, addiction history, addiction potential. Now we got the coping, non-adaptive coping. Catastrophizing, that's the person that walks in and go, this is the worst thing that could have ever happened. Well, really, you and your wife are okay, right? Yeah. Your kids aren't dead, are they? So it's not the worst thing that's ever happened, but that's what people do with certain physical problems and pain issues. Kinesiophobia is the fear of movement. How many of you are aware of your patients having the fear of movement? They're afraid of re-injuring themselves. It's a pretty common thing that I see. So we have to be realistic about helping them realize that you may not injure yourself. Let's get you doing things and see what we can do to get you back as strong and as functional as possible. That's a normal profile on the mirror. You see up there in the corners, the overall risk level? That's an average risk, so it's 5. So this person here, the overall risk level is pretty average. It's not something you have to be worried about. So you can see there's percentile ranks, the scale names as well. T-scores are where you average. It's actually a standardized score so you can compare everyone. And then the percentile rank. How does that present? Percentile ranks looking, are you at the 66th percentile for patients? Are you 40th percentile, whatever. Okay, this is a person with a high risk. So right out of the chute, you can see we've got the primary risk factors are present. So that's stop. We got to be careful right now. We got to address these issues that need to be undertaken before we do anything. But you got some cautionary ones as well. So this particular profile, auditory hallucination, suicidal ideation, violent ideation, pain level, 10 out of 7 areas of the body. Now, I find it really interesting with some of my auto cases where somebody gets in a mild whiplash injury and they have pain in every region of the body, including genital. It's kind of anatomically not really consistent that that's going to be very accurate. Low risk. This person's actually below the average of. So you don't have to worry so much about these people from the test if they're struggling with, if they're not struggling with any of these issues. They're within the average of the average patient. I do believe that it is so important for us all to work together with all of our diagnostics, all of our acumen and understanding, but come together as a team. And we can't do it so much in multifactorial pain clinics like they have done in the past, because they just don't make it. It's financially prohibitive right now for the most part. So we can work together those a virtual clinic, and it is my hope that you all will do that. I would like Jackie to come up, and I was unaware that Pinnacle had the services, some of these new services. When I worked at Coors, I worked very hard to stage people back to work. One of the hardest things for me as a pain psychologist is to have a company there or a workplace that says, you're 100% okay or nothing. You know, it kind of reduces the successful outcomes. So Pinnacle, which from my perspective, now that's not 30 years ago when it was CCIA, it was a little different, but they are probably one of the most progressive work comp insurance companies, I think, in the United States, just from my experience. So.
Yeah, and I understand that we're a bit short on time, and so I'm just going to give a very quick overview of what return to work services are available through Pinnacle, and then there's also a table out in the Learning Lounge we can talk about more resources. But what Return to Work does with Pinnacle is we partner with physicians and with all the other disciplines within our company to assist with the process and facilitate the return of work for our injured workers. And so when we look at the whole person, when we look at injured workers, we fully understand that work has such a powerful impact on their self-worth, their happiness, their success, and their treatment. And so again, our return to work consultants help facilitate identifying options, looking into what the barriers are with someone working after their injuries, and actually go on site to the employment sites to look at the individual tasks that are available and help identify things that are appropriate within the abilities of that injured worker. So.
In closing with that, I would just like to say that I've been working with the Colorado Vocational Rehabilitation Group for Colorado for 25 years. 25 years ago, 4 out of 5 people in Voc Rehab were homeless or coming out of prison. Now it's changed because vocational rehab changed because the money from welfare and the vouchers for rehab were abused, and so now they gave it to the states, and they have actually some pretty neat programs. So I believe it can be helpful, even with that resource for some of you, if they can help, as well as Colorado Voc Rehab is a great thing to mention to your patients, because it may give them hope, which is, I can see where I'm going so I can leave. So I think it's important to utilize all the resources we have available. So do we have any questions quickly before I get thrown off?
Is your MIR available?
It will be completed. It's actually been completed. We had a little glitch, the publisher, so it'll be out in December. But we can send you information on it now, if you'd like. Any other questions? Thank you very much.